Welcome to today's webinar from the Agency for Healthcare Research and Quality about introducing the CAHPS Outpatient Mental Health Survey. My name is John Bakdash. I'm a social science analyst for AHRQ and work on the contract that supports AHRQ's Consumer Assessment of Healthcare Providers and Systems Program, or CAHPS program. Next slide, please. Briefly, I'm going to go over a few housekeeping items today for the webinar. First, if you have any issues with sound coming from your computer audio, you can connect to the webinar audio using your phone by clicking on the phone call to find the dial-in number and meeting ID, or you can use Call Me to enter your phone number and receive a call back from Zoom. If your computer freezes during the presentation, you can try logging out and logging back in. At any point in today's webinar, you may ask a question through the Q&A feature. Look for the Q&A icon next to the Raise Hand tab. We encourage you to share your name and/or organization or role when you type your question. Speakers will respond to your questions during the Q&A portion that takes place at the end. Please note that the Raise Hand feature and chat have been disabled. You can download the presentation slides, view the agenda and speaker bios at our event website, https://events.westat.com/CAHPS, CAHPS. Last, there's one Zoom link for the entirety of today's webinar. If you leave at any time, you can rejoin using the same link provided in the email that you registered with. Next slide, please. Today, I'd like to introduce our speakers. Dr. Paul Cleary is going to be our moderator. We also have Dr. Lee Hargraves with us and Dr. Daniel Mullin. And myself. Next slide, please. So first, we're going to, as an overview of our agenda today, I'm going to provide some background on the AHRQ CAHPS program. And then you're going to receive information specific about the overview of the mental health survey, how it was developed, what its purpose was, how it was field tested. So Dr. Paul Cleary is going to go over the CAHPS mental health survey. Dr. Lee Hargraves is going to go into details about how it was developed and its rationale. And Dr. Mullin will be going through the process for testing this new survey, some of the questions, and then at the very end, we're going to have a Q&A session. Next slide, please. Welcome. Thanks for joining us today. So now I'm going to go over a brief overview of the CAHPS program, and CAHPS stands for Consumer Assessment of Healthcare Providers and Systems. For new users, we want to provide an introduction to the CAHPS program, just an overview of it. Next slide, please. I'm going to tell you a little bit more about the Agency for Healthcare Research and Quality, AHRQ. So you can see how the CAHPS program fits within AHRQ. AHRQ is a research-based agency of the U.S. Department of Health and Human Services, and we are the lead agency charged with improving the safety and quality of America's healthcare system. As a research agency, we do not have authority to require the use of our tools or surveys or require that you submit any survey results to us. If there are requirements or options to use these CAHPS programs as part of a program, these requirements do not come from AHRQ. They could come from another organization or agency. We do not require the use of any of our tools or products. And AHRQ has a long-term investment in survey development, including research and hosting databases for these selected CAHPS surveys. Next slide, please. I'd like to define patient experience next. And patient experience is what actually happens to patients during their health care or using a health plan. So the range of interactions they have with the health system. And this slide shows some of the examples: access to care, communication with clinicians such as doctors and nurses, getting information. And I want to emphasize that patient experience is different from patient satisfaction. Patient experience measures what happens to patients during their course of healthcare, whereas patient satisfaction is expectations about a healthcare encounter, whether the expectations were met and whether a patient is satisfied. So satisfaction is very different than the experience here. And the CAHPS program focuses on measurement and understanding of patient experience with their healthcare. Next slide, please. So there are a variety of CAHPS surveys measuring experience in different settings, experience with providers, experience with facility-based care, condition-specific care, and health plans. Today, we're going to be focusing on mental health care with experience with a condition-specific care. So this is just to show you the variety of CAHPS surveys. Next slide, please. Here are some of the essential uses of CAHPS surveys. Can be used for quality improvement, identifying areas that can be improved, public reporting for accountability, and helping patients select particular healthcare providers or facilities, certification and recognition, also for value-based purchasing, in addition for research. Now I'd like to pass it off to Dr. Paul Cleary. Next slide, please.
Thanks, John, for that great introduction. Can I have the next slide, please? Today, we're going to give a very short history of the CAHPS mental health care surveys, in part because there's frequently confusion among different versions, and we'll try and explain that. And then I'm going to hand it off to Lee Hargraves, who's going to describe findings from the qualitative research among people with mental health or substance use disorders, and then key findings from 2 field tests, one with state Medicaid health plans and one from a 2022 pilot test in family medicine practices. Next slide, please. So that in general, the CAHPS mental health surveys are designed to assess and guide improvement of patient experiences with mental health and/or substance use services. When we use the term behavioral health, we're really using that umbrella term to encompass mental health and/or substance use. The predominant survey since the late 90s has been what we refer to as the ECHO, the CAHPS Experience of Care and Health Outcomes Survey. There also, in 2021, we introduced supplemental items on access to mental health care services for the CAHPS Clinician and Group Survey and the CAHPS Health Plan Survey. And the survey that's going to be the focus of today's discussion, which was introduced this year, is the CAHPS Outpatient Mental Health Survey. You may also have heard or be interested in several of the registrants asked about inpatient care. We are in the process of developing a CAHPS inpatient survey. We've done some work on that, and we'll be doing field testing in the spring of next year, and we'll be publicizing that at another time. Let me just mention a couple big picture issues. One question came up, is the CAHPS Outpatient Mental Health Survey a replacement for the ECHO? And the answer is yes. It is the evolution, and Lee will explain why we've developed the new one. The supplemental items are very different. They're intended to go into the Clinician and Groups Survey or the CAHPS Health Plan Survey. Any of you who are using that survey can add these items, and they will measure access to behavioral health services. One distinct characteristics of the ECHO and the new CAHPS Outpatient Mental Health Survey is that they are intended for users of mental health services or behavioral health services. So they're not meant for a general health plan population. Several people have asked, can we just add them? Why not just add questions to health plan CAHPS? And the answer is, these surveys apply to a subset of individuals with very particular healthcare services and needs. The survey would be too long if we added it. So they're a very distinct sampling and approach to that. Next slide, please. So as I mentioned earlier, I'll just go through this very quickly. Back in the late 90s, the CAHPS team developed a survey called the Consumer Assessment of Behavioral Health Services. In 1998, NCQA convened a measurement committee to evaluate available instruments for assessing behavioral health care. We reviewed the MISIP, Mental Health Statistics Improvement Program survey, and on basis of that information and the information that NCQA compiled, developed what I mentioned was the CAHPS survey. There was tremendous use. The most widely used survey really was the MISIP survey. And so in an effort to consolidate and focus the field, we did a fair amount of testing of the CAHPS, which was the CAHPS survey at the time, the MISIP, and then what we developed as a hybrid. And that's what led to the Synthesized Experience of Care and Health Outcomes Survey, the ECHO. And the ECHO has basically, until recently, been the CAHPS Behavioral Health Survey. We subsequently did cognitive testing, field testing, there's a literature available on the development of the ECHO. It was trademarked by AHRQ in 2002 and introduced and endorsed by the National Quality Forum. So as I said, it hasn't been updated in many years, and increasingly we were getting requests and interest in an updated survey for reasons that Lee Hargraves will refer to. I'll just mention before I pass it on to Lee, a couple of characteristics of the ECHO. I mentioned this before, but it's specific to behavioral health, and it's focused on experiences with providers, insurance, and managed care organizations. For those of you who are familiar with it, you'll know that there are actually two distinct versions. One was for managed behavioral health care organizations, and one is for managed care organizations. And that's a little bit of an anachronism, because at the time, that's how consumers and providers thought about how behavioral health care was provided. As I mentioned before, we maintained consistency with other CAHPS surveys for many years, but it's been a while before it has been updated. And because of a tremendous amount of interest and queries, we focused on developing a new survey. And now I will pass it on to Lee Hargraves.
Thanks, Paul. I'm going to quickly just go right to the discussion. But one of the principles of a CAHPS survey is it keeps up to date with what's going on in the healthcare system. And the ECHO survey, as Paul was describing, was built for the 20th century healthcare system. And in the last 20 years, or more than 20 years, actually, there have been several changes in the system. We've found this out through both talking to people in small groups, focus groups, and looking at the literature as well. And back in the original days when this survey was developed, health plans, mental and physical health was separate entities in many ways. And through legislation and regulation and advocacy, the system has changed where more and more people want to think of mental health care as a part of a holistic system that covers both physical and mental health. The Affordable Care Act, which was 2010, made mental health an essential benefit. And then again, there have been a lot of advocates like the National Alliance on Mental Health working to reduce stigma. And one of the issues that's most important, I think, is to think that mental health is a large proportion of the population will experience some need for mental health care in any given year, 20%, 1 in 5. So one of the things that we did at the Center for Survey Research was we did, and particularly my colleague Carol Cosenza, who worked on a lot of the testing back in around 2016, 2017, doing small group interviews, again, focus groups, and doing some one-on-one cognitive testing, taking the questions that were in the ECHO survey, presenting them to people who have conditions for which that survey is appropriate, and then asking them about the questions, what makes sense, what doesn't. And then also, as part of the development process, we convened a technical expert panel in 2018. We did additional cognitive testing using the input from experts and stakeholders, and again, advocates who were members of the panel. And we did more testing, again, one-on-one cognitive testing. For those of you that aren't familiar with that, you present the respondent with the question and then ask them, what do the words mean to you? Put it in your own words. How'd you come up with your answer? That sort of thing. We also did some field testing with partners from the Department of Veterans Affairs, who have been a very collegial group who've in many ways been on the front lines of saying, let's roll this out and see how it works. So we did an online panel with the VA. And then more to what I'm going to be talking about for the rest of the talk is the field testing we did, rolling it out in either a sample of people who are being cared for by Medicaid or with a sample of patients in primary care settings. What we learned along the way in cognitive interviews is that some of the words that we were using in the ECHO survey didn't make sense in the way that the healthcare is structured today. For example, we asked people about, did you use up all of your mental health benefits? For those of us who were around in the 20th century, there were plans that would say, you only get so many visits, and that's no longer an issue. And then also how the delivery system, talking to people in small groups, the delivery system has changed. The relationships between plans, providers, and patients have been evolving over time. And as we know, all ways of interacting with healthcare have been changing. For example, we do more and more of our activity through video conferencing. And again, for mental health, that is a key component of mental health care in many places, doing sessions online. But one of the things I will note is the more things change, the more in some ways they remain the same. We find that patients build their own system. They have one person who will help them with getting medication and another person who might be doing counseling. So, and that's why I would say, people sort of build their system to help them with their needs. So what did we do before doing the field testing? We dropped some of the questions that didn't make sense. We dropped questions about the health plan. Again, ECHO had outcome questions in it. We removed those for the survey. It's not to say that you might not want to ask those questions if a user wants to know about, for example, how a health plan is interacting with patients. One of our field tests was with Medicaid. We asked a few questions about the plans. And again, functioning is an important piece and people of care, and people might want to ask that, but we didn't put those in the core survey. We added questions that made sense, such as questions about how your family and friends might have been involved in care, whether you were given information about your rights as a patient, whether you felt that you could refuse a specific type of treatment. So those were added to the survey. So I'm going to talk about the two field tests. The first one was with health plans. We partnered with a state Medicaid agency, and they helped us with this field test. We did samples of enrollees in 4 different plans. We had criteria that they would be adults 21 and over. And then in the last 6 months, we wanted them to have either mental health diagnosis or a substance use disorder, or both. And that's what we did in both of the field tests. We followed a fairly standard protocol. We sent, in this particular field test, we sent potential respondents a notification letter saying, you've been selected for this survey. It's very important. It had the letterhead of the agency on it. It also had a URL for a web survey. I will tell you now that we're doing more and more with adding QR codes, but at this point we did URL, which means someone's got to type that in, but we did get responses that way. And then we did 2 mailings of a questionnaire, cover letter, business reply, and then did the survey. And I don't know how many of you out there are doing survey work, but of course the greatest trend in the last 25 years is it's getting more and more difficult to do those surveys. When we talked to our partners at the state Medicaid agency, they said, yeah, we've been seeing that too. We had a very limited response to the survey. Fortunately, for those of you testing surveys, it's always a good idea to ask for more sample than you need, because it really helped us out. We did a second mailing. We switched to a different logo, thinking that might help if it's not coming from the state. What if it's coming from a university? Again, we did 2 mailings of questionnaires. We didn't do the pre-notification to kind of keep things on track. And I'll just very quickly, this is a table that shows you our response rates. The first survey, we started with the push to web. And then we did the 2 mailings. The second, we just did the mailings. Actually, I kept thinking the response will be better, and it wasn't, which probably is an indication of more contact with your potential respondents, the higher the response rate you're going to get. But both were around 10%, 10.6 and 7.7, which is not what we wanted, but that's what we got. I would ask that you also think about, when looking at you're going to have bad addresses and people who move out of state. We did that, remove some of the people from the denominator for calculating response rates, but still it's not what we wanted. And then finally, I would just say that, one of the things that people are concerned about survey length, we made a survey that appeared shorter, was 4 pages rather than 8 pages. Actually, the response rate was slightly higher for the larger survey, meaning that the text was larger, more space in the survey, a little bit friendlier with logos, and made it look prettier. Anyway, but the thing we learned in the Medicaid survey was it's going to be hard to get a high response rate. So the second field test, thinking that it would be better to do something closer to where patients are, working with a practice. We worked with 4 family medicine practices. We did sampling, again, thinking about people who've had a mental health diagnosis, people who've had treatment for a substance use disorder, or both. And this was in 2022. We also did adults. Here we did 18 and older. And we did some exclusions because we're looking at medical records. We were able to exclude someone who was having a diagnosis of dementia rather than a mental health issue. Well, and then again, we did this in English and Spanish, again, giving people a URL. We did the standard kind of mailing of 2 paper mailings through the U.S. Postal Service. We offered it in Spanish, particularly upon you could request it. And then, of course, you could do it on the web in Spanish as well. So just a little bit about results. We're working in family medicine. The bar chart that I'm showing you here shows that people were getting their prescription medications for mental health, mostly from their primary care providers. And then also they were getting counseling, and counseling was mostly from clinical psychologists. And the reason I put these 2 sets of bar charts up, because the survey is mostly about getting prescription medication for mental health conditions and for counseling for mental health. Again, the question was asked in the survey: in the last 6 months, have you taken prescription medicine for any kind of mental health reason? Again, 3 different groups of patients: those with only a mental health diagnosis, those with substance use disorder, or those who had both. Overall, of all people who we got to respond to the survey, 62.5% said that they were taking medication for a mental health reason. Similarly, for counseling, all the way on the right is everyone in the last 6 months, did you get any mental health counseling for any reason? 53.6% of all of our respondents said that's what they were doing. As you will also note, those who were in the sample purely for a substance use disorder were much, much less likely to report either getting mental health medications or counseling. 45% reported both getting prescription medication and counseling. So one of the things that we do with CAHPS surveys is we try and create measures to measure performance. We use composites. For example, we'll have an access composite, which combines different kinds of access points into the healthcare system. We'll talk about communication, how well providers communicate with patients. We'll also note that sometimes we do single items to create measures. We always have a 0 to 10 overall rating. Here it's for counselors as the provider. And then again, for really quickly understanding what's going on, we often focus on the top box response. You'll hear people say it's a top box response. What does that mean? If I ask you if it happened never, sometimes, usually always, and always is the most positive response, I'd like to always have a provider who listens to me. That's the top box response. So again, for access, there were 2 questions that we used to create a composite. How difficult was it to find a mental health counselor? And that's of some respondents who in the last couple of years were actually trying to find a counselor. And then for those who had a counselor in the last 6 months, how difficult was it to make appointments? Again, the top box is the most positive response. So for that question, it's not difficult at all. Similarly, for communication, did your mental health counselor listen carefully to you? Did they show respect for what you had to say? Those are very common questions in CAHPS surveys. Always is the most positive response. If I ask a respondent in the last 6 months, did you talk with your main mental health counselor about setting goals? The most positive response is a lot. How much did they consider what was most important, well, what was important to you when setting goals for treatment? And that's the most positive response here. So in general, for the family medicine field test that we did, about half or 2/3 of respondents were reporting some difficulties in accessing. Again, that's sort of thinking about, using the measures as a measure of room for improvement. There is room for improvement for access, particularly for finding a counselor for those who are, in the last couple of years getting a new counselor. About 1 in 5 of respondents reported that they had communication problems with counseling. Again, if we're creating composite measures, one of the ways that you can assess a composite measure is the extent to which they are internally consistent. We'll measure something called Cronbach's alpha, for example, internal consistency, reliability. The counseling access measure is actually measuring 2 different things. How hard is it to find, how difficult is it to find a counselor? And then once one is found how difficult is it to make appointments? Those are not measuring the same thing. They have a reliability coefficient of 0.52. Communication works much better as an internally consistent measure, meaning that respondents who say that their counselor is listening are also saying that they're treating me with respect. The coefficient there being 0.89, which is for internal consistency very high. We could also roll in the goal setting, and that still keeps the consistency very high. But one of the difficulties is, as a measure, is the denominator shrinks from 223 to 170 respondents, which is something that one should consider. We also look at inter-unit reliability and thinking about CAHPS measures as measures of performance. And what that means is how well does this measure distinguish between those 4 practices that were participating in this particular field test. And in other words, 4 distinct, differently located family medicine practices. Again, if you're thinking that the measure should be 0.6, 0.7 for inter-unit reliability, this is one of the difficulties of using this as a measure, particularly for communication. The reliability coefficient is very low, meaning that you would have to survey hundreds of patients to be able to detect the differences between the practices. So what I can say in summary is that, again, survey response is a challenge. And I think that for everyone doing patient experience survey work, we're going to have to work harder. We're going to have to make more contacts. We're going to have to use more than one mode to get messages out to the potential respondents and to get the survey returned. That's a given. Even though I thought it would be better in the family medicine practices, it was not. But it was slightly better, but it was not huge. One of the things to consider also is that we included those who had only a diagnosis for substance use disorder, those with only a diagnosis for mental health conditions, and both. The experiences of patients differs significantly, by the kind of care they're getting and the conditions they have. I do think that the composite measures are holding a promise, particularly for internal consistency. But I think there's more work to be done. The construct validity is another way we think about assessing patient experience measures. How well do the measures we have, the composite measures and the goal setting measure, how well do those predict overall ratings of care? And I would have to say that there's a high correlation, and it makes sense if someone's listening to you and explaining and I mean, listening to you and showing respect, then it makes sense that you're going to give them as a respondent a higher score on their overall 0 to 10 rating, whereas 0 is the worst mental health counselor and 10 is the best mental health counselor. I mean, that makes sense. That's what construct validity is all about. Are the measures associated in a way that makes sense to us? And then finally, I would say that one of the difficulties is that we found is there were people that we sent surveys to and they sent them back and they did not check that they had either counseling or prescription drugs. They, in other words, reported that they didn't need care. And I think that I'll just pause to one more thing on that topic is that I think it's really important when thinking about creating a sample. We selected because they had a diagnosis for either of those two conditions. I think it might be better to sample where someone has more than one diagnosis. And then before I turn it over to Dan, I would just say it's also very important to have someone on your team who is a collaborator who knows what's going on in the system. And that's why I'm switching to Dan at this point, because Dr. Mullin has been a valuable partner for us and is a psychologist providing care and knows more about that than I do. Thank you very much. And I'll turn the slides back to
Yeah,
Dan.
thank you, Lee. I'm going to talk a little bit now about how we think this survey might be helpful, to whom it'll be helpful, and why it might make sense for people to use this. We could go to the next slide. So here's just a list of the use cases that might be relevant. We think that payers, both private and public payers for healthcare and mental health services, might find this survey to be helpful. We think that accountable care organizations and health systems and hospitals may have a use for this. Obviously, we also think that outpatient mental health and substance use disorder treatment organizations will find this relevant. As Lee alluded to, some of the validation work that was done in primary care practices where mental health was being delivered both by primary care physicians and co-located mental health providers. We think that this would be particularly relevant to those settings. And we think that as we think about providing quality care, a standardized measure like this can be helpful for monitoring changes over time, and for making comparisons between practices, trying to determine which practices or organizations are doing the best at providing good patient experiences of care. We do want to make a note, however, that this survey was not developed as a tool to make comparisons between individual clinicians. So if you were a manager or a payer and you were trying to determine which individual clinicians were providing the best patient experience, we didn't set out to make a tool that could do that, and we wouldn't recommend using this in that way. If you could go to the next slide. So let's dive a little bit deeper on who, and I guess getting a little bit into why. So I come back to the IHI definitions for quality. We think about reducing the cost of care. We think about improving the health of populations and improving the patient experience of care. And it's obviously there that this survey is most relevant. As a clinician, as a practicing clinician myself, I see tremendous resources being dedicated to trying to understand value or quality or performance through process and outcome measures, things like A1C or blood pressure or self-reported depression using the PHQ-9. That's where our systems are focusing an awful lot of energy. I think this tool really helps us fill in a gap for one of the three parts of the triple aim, which is making sure that we're paying attention to the patient's experience of care. Sometimes the easiest things to measure are the things that get measured quickly, and I would say I think that's why we put so much focus on the PHQ-9, because the data is there and available. I think supplementing that kind of data with things like results from this survey are going to be helpful to see if patients are telling us that their experience of care is helpful to them, it's a positive experience that would make them want to come back and get more care. Next slide. So I want to just talk a little bit about some of the practical issues of doing this. Again, as someone who's in the front lines providing care and working with my staff in the front office, I would just say, please, if you're going to send out a survey like this to patients, you want to alert the frontline providers and the frontline staff that this survey is going out. Because often if patients have concerns or questions, that it's the frontline staff and the frontline clinicians that are going to be the first ones to get those questions. Rightfully so, many patients are concerned about their privacy. They may have questions about why they received this survey. Many patients are concerned about all sorts of financial scams or other scams that are out there. And you can be sure that if you survey a few hundred or a few thousand patients in a practice, some of them are going to show up in that practice asking, why did I get this survey? And if we're surveying people to understand their experience of care, we don't want to make their experience of care worse by the survey process. So we want to make sure that those frontline clinicians can answer the questions. And I would say this is probably true for whenever we survey on patient experience, but particularly when we're surveying people about mental health concerns or substance use concerns. Many of these patients have heightened vigilance regarding issues of privacy and safety. They're rightfully concerned about stigma. And sometimes for certain mental health conditions, the nature of the condition makes them even more vigilant or concerned about their privacy or safety. So if we could go to the next slide, here's just some sample text that'll be available to you. This is the sort of thing that I think would be helpful to put in an email or to inform your frontline clinicians and staff. We say here, next week, our practice will mail patients a survey inquiring about their experience with mental health services. These surveys are intended to improve our ability to address our patients' mental health concerns. The surveys are optional. Patients are not required to complete them. If a patient raises questions or concerns about the survey, please reassure them that their personal health information is kept private. The individual responses are not connected to their names or any other identifying information. And if patients have additional questions or concerns, please connect them with the practice administrator or whoever your system would want to connect them with. Again, I think just including this helps patients who get this survey and have questions be sure that it's safe for them to talk to people about their mental health and substance use issues. Again, in the process of measuring the quality of care, we wouldn't want to do anything that would make someone reluctant to engage with that care. And I think you can go to the next slide now. So I think I'll hand it back to the other members of the team for questions and answers.
Lee and Dan, thank you so much for a great presentation. We have a lot of questions. In the interest of time, I'll move through them relatively quickly. One comment I made was that the new CAHPS Outpatient Mental Health Survey was meant to replace the ECHO. And several people have asked, well, will we be getting rid of the echo? The echo is on the website, will be maintained on the website. We know that people are using it and may want to continue using it for a while. We don't have a specific deadline for removing it. Typically, as CAHPS has developed new surveys, we'll keep the previous version of the survey online on the website for a year or two and gauge interest in how it's being used, whether it's being used and needs support. And we really assess it. So we don't have a hard and fast rule on that. Another question that's easy to answer, is it adult only? And the answer is yes. As you may have gathered, the difficulties of getting access, ensuring confidentiality, getting response rates are formidable for adults. And we really have not even tried to broach the issue of care for children. Someone asked earlier, is it available in Spanish? All the surveys I referred to that were mentioned are available in Spanish. To go back to, I'm sure one of the issues many of you are focused on is the response rates that Lee alluded to. One of the participants asked a very insightful question, and he said, what was the overall rate of people who indicated they didn't receive care, which was quite a surprise to us. And I'll turn it over to Lee, maybe to comment on that issue and some of our thoughts about how to address that potentially in the future. Lee?
Sure. If you recall, the survey has 2 questions that ask in the last 6 months. Did you have a prescription for a mental health condition? Did you have counseling? And there were, again, a significant number of people, much more than I thought, who didn't endorse either of those 2 questions. They said no. Later in the survey, we actually asked, did you, and I'm not going to have the exact percentage in my head. It doesn't work that way. But what I would say is, we asked, did you get all the care you needed? And one of the response options was, I didn't need any care. And there were, I would think over 20% who said I didn't need care. So that was why at the very end, I alluded to, I think it's more than one, one visit with a diagnosis for a mental health concern. I think you'd want to look at 2 visits. But partly it's, thinking about how people code visits, and I'm, again, not a clinician, but I don't think we want a one-off, I gave someone a prescription for, something that got them into our sample. So I think that's one of the issues here. Again, I'd love to do another field test, but, you only have so much time.
Thanks, Lee. One of our friends and colleagues, Francis Fulham, asked several related questions. One is, how many institutions are currently using the survey? We do not monitor use of the survey. We know of several systems, states, we don't have a database of that. Another question asked by a pre-registrant was, what about a CAHPS database? Will we have a comparative database for behavioral health surveys? And the answer is that depends on use and interest. Currently, there's not sufficient widespread use to justify a database, but we revisit those issues periodically. 2 other questions, related questions that Francis asked are, do we provide support for trying to interpret results and make an improvement? Although Francis didn't ask about this, we do offer support about the survey. WestStat provides information. We contact people with experts in terms of implementation and our experience. In terms of interpreting and using the results, the main resource that we direct people to is the CAHPS Improvement Guide. It's on the website, and it's not specific to behavioral health issues, but offers a panoply of information about how to assess data, how to analyze data, and how to use them in quality improvement efforts. I just got several questions about the inpatient survey. We're trying to focus on the outpatient survey, but I will just mention it, that we have been doing work on the inpatient survey. We've done a review of the literature, the available instruments. We convened a technical expert panel. We've been doing focus groups. We actually just completed 3 cognitive interviews in Spanish this week, and are going to be continuing that work. As I mentioned, we're targeting spring of 2025 for field work. When it will be available is, it depends on how many modifications we have to make. And quite honestly, our ability to field test the instrument, our main interest right now is identifying partners who we can collaborate with and test that. And I'll mention one other inpatient. Several people asked about the PIX. Again, we're focused on the outpatient here, so I won't emphasize this. Our close colleagues and collaborators at Yale developed the PIX. There are many differences in terms of content, format, response task, and so on. We think very highly of the work done on the PIX. And in fact, one of the things we've discussed with our colleagues is doing a comparative test of the different instruments. So hopefully in the future, maybe on another webcast, we'll be able to offer more information about those interests really, and how they're similar or different. Okay, back to the outpatient survey. Someone asked about, have you tried using text? And in fact, we have for 2 or 3 years now done various experiments, field tests with texting. And maybe I'll turn it over to Lee to sort of summarize both the potential, but also the barriers to using text for surveys.
Thanks, Paul. I'll say a couple of things. I mean, we have done, in fact, we have a paper out where we did some testing of texting. Of course, one of the difficulties in doing texting in some systems is that texts are used often for reminders for patients to get their appointment. I know that I get 2 or 3 when I have appointments, and I'm sure many of you do. And there are concerns from organizations about if we start using that same system for our survey work, that we might get a lot of people saying stop, which is part of the we don't want to lose the ability to remind people and do that. I think it's also an issue of people have to have permission explicitly to be texting me. But I do know that is, so it depends on the organization. I think that if an organization is routinely doing that, I do have one personal provider who does send me a survey via text, but that's a rarity in our world. But I think it's a reasonable idea, and it's something worth thinking about, but it's also very difficult. And you might want to do like we did and talk to your attorney about how that fits into your system. And it's similar for email. I mean, I think email is actually a much more viable method, and it's being done. There are tests of that going on, but here we focused on only 2 contacts. But I would say that multiple contacts is really going to be the way to go in the future. It's not going to be getting everybody through the same door.
And Don Lauder asked that question. He also asked, any chance of selection bias based on the method of contact? Not only is there a chance, there's well-documented differences in who responds to different contact methods. I don't know if we can post this later. We've done a pretty major review paper of methods to increase response rates and, perhaps more importantly, representativeness of different samples. I think the short version for today's webcast is that, to sound trite, different people are more likely to respond to different methods. Young people, different people in different communities. That's one of the motivations for, in general, CAHPS recommending multi-mode approaches. And you can see on almost any survey we've done, we've tested different approaches from web to mail to telephone to different outreach kinds of methods. So in general, the answer is yes. Different people do respond with different probabilities to different methods. We have been regularly doing research on that. And as I mentioned, this review paper is, I think, one of the better summaries of how different methods affect how different people respond. Francis also asked about diagnosis of dementia. Again, That's he's correct. It's a very challenging group to get feedback from. The most work we've done in that area was when we developed the nursing home CAHPS. There was a lot of discussion about what proportion of the population could answer the survey, how to characterize that population so that you knew what the case mix across institutions was. To date, we haven't run into that as major a problem on the mental health and substance use survey problem, but I don't know, Lee, if you had any other comments on that issue.
No, I think that is again an area where we need to be doing more. I have a colleague, for example, who's testing survey methods using video, because that's something that so many people have. So for someone for whom reading and responding to a survey via all of the methods we're talking about, that might want to do it in a different way, but it's hard. I'll admit that.
One other question, which I think is a very insightful question, is even though we've described almost seismic shifts in the landscape of how behavioral healthcare is financed and administered, there are still standalone organizations. This is true, obviously, for outpatient. It's also a major issue as we develop an inpatient survey. And the original ECHO was developed so that we could target questions to specific provider organizations and ask about the performance of those organizations. And in streamlining and modernizing the outpatient surveys, many of those questions are no longer included. The question is, could they still be used? And the answer is yes, of course. We have questions about health plan, about system functioning, the availability of care, the accessibility of care, and we've tried to make those generic. And that's one of the reasons we're going to be keeping the ECHO up for a while to see people. Matter of fact, we had a whole set of interviews with healthcare providers throughout the country, and they were emphasizing the kinds of questions one would want to ask about the provider group. So we will be monitoring the use, getting feedback from users, and also that's one of the reasons for maintaining the ECHO and the ECHO type questions on the website. One of the questions I alluded to this was, will AHRQ be compiling benchmarks for organizations? And I think I answered it, but John, you want to just mention sort of the AHRQ's approach to benchmarking and the CAHPS benchmark database?
Sure, thanks for that question. So at this time, there's no plan to provide benchmarking data. And I think if this is something you're interested in, we would encourage you to contact us. There are probably not enough submissions at the moment, but it's something we would want to revisit in the future and something that may be helpful. So it's not off the table. Thank you.
A question came up about the MISIP. No, this survey does not replace the MISIP. The MISIP is, I think, probably the most widely used survey of this type in the country. We're constantly working with different entities to see if we can meet the needs and reporting needs of different entities, and that's an ongoing process. This was an attempt to update the ECHO and develop a survey that's more consistent with the way behavioral healthcare is administered and financed, and that is compatible with the other CAHPS surveys. In parallel, we're working with different entities to see the extent to which it can meet the needs of both organizations and regulatory organizations. One question about providers and goals. Do we have any recommendations for capturing that data? I don't think we do. As you can see from today's presentation, one of our major issues is getting adequate sample to look at providing entities. And maybe as we get better penetration, we'll be using those for providers, but that's not part of our aspirations right now. One of the last questions was, again, about response rates. Given that it's about 10%, doesn't this call into question the feasibility of using those? What specific plans do we have to improve response rates? And have we asked providers, caregivers, advocates for ideas on how you can improve patient survey response rates? As you might guess, a major part of our attention and effort since the field tests that were described have been, and as Dan described, working with different groups to think about what's the best approach to engaging, I don't know if I like the word, individuals who are receiving care of this type, what would encourage them to respond. As Lee mentioned, survey rates have been going down in general. We have not done field work with anyone who's been surprised about low response rates on behavioral health care. There's issues of confidentiality and sensitivity. One big area that Lee has mentioned is a very high proportion of people who we surveyed didn't conceive of the care they received as mental health or substance use care, even though we have information from the medical record that they had received such care. So this is a major focus of ours now. And yes, a 10% response rate does compromise the utility of a survey. So we're working on several fronts, working with provider groups to think about how to communicate, as Dan has mentioned, to thinking about how to frame the survey or select a survey so that the survey is more salient to those individuals, and various ways to reassure people about confidentiality. I don't know, Lee or Dan, if you have other comments about this pretty key issue.
I think you touched on sorry, Dan.
Go ahead, Lee.
I think you touched on a couple of them, but one of them, I always think about is people are getting surveyed all the time for everything, and how to let people know in a setting, in a primary care setting, that we're going to ask you these. You're going to get a survey. I'm not going to tell you how to respond, but I'd tell you that it's really helpful for us to do it. I know, that's important. I think also on the sampling, I think a lot of, again, someone asked, about the people who said they didn't need any care, and about 1 in 3 of our respondents said they didn't need any mental health services. And I think doing a better job with the denominator, making sure that someone really was getting care. I have a feeling a lot of folks looked at the survey and said, this is not about me. And might have, so 2 fronts, talking to patients in the setting and letting them know it's really an important activity, and making sure that people in the sample are there because they need to be. Dan?
Yeah, there's a little bit of a conundrum here, because in some ways the distinction between physical and mental health issues is arbitrary. And I think that's kind of what makes this difficult. So is insomnia a medical problem or a mental health problem? Reasonable people might disagree and think about that differently. I think when we think about ways to increase response rates, I guess my initial reaction is we probably want to put that task on staff who aren't providing the care. I think particularly when you talk about people providing counseling or psychotherapy, I think you're really going to bias your sample if your therapists are asking the people who are deeply engaged in treatment to respond to the survey. And the sort of people who are poorly engaged or less well connected might not be then getting the same message to complete the survey. So I guess I'd want to put it on staff and rather than clinicians, I think is my response. Yeah.
And Dan, you might be the person, one of the questions came up about using it for quality improvement. Do you have other comments about ways in which this is how you interpret and use these data?
Yeah, I think just in piloting the survey in practices I'm affiliated with, we fed the initial responses of the draft survey back to the frontline clinicians and the program directors for the clinicians. and just ask them to look at it and see what their reactions were. I think what we heard, not surprisingly, what we heard from the clinicians was, well, if patients are complaining about access, please hire more clinicians. We all want more clinicians. And, you know, I think that's one way to, I think that's going to be the clinician response to a lot of surveys is where there's a mental health access crisis and we need more of us if you want to improve quality. I think you're going to hear that, but I think then you can ask your frontline people to identify other things on the survey, things that might be under their control that they could change in terms of how do we streamline the process for connecting patients with care. What are all the administrative steps that happen in between identifying someone who might benefit and actually getting them a meaningful interaction with a clinician? How can we reduce all those administrative things that need to happen to improve the patient experience? So I think you'd be looking at just running PDSA cycles and then retesting with the survey once a year to see if you move the needle.
Great. And a question we don't really have time to answer before I turn it over to John. It has to do with reporting requirements and accreditation, but we are working with several entities and organizations to see how we can maximize the utility of the new survey, the way ECHO and NISIP are used for meeting multiple accreditation and reporting requirements. But time flies when you're having fun. I'll turn it over to John to mention feedback and the final. Go ahead, John.
Thank you. I just want to remind anyone, if you joined late today, a replay of today's webcast will be available on the AHRQ website. We also periodically send email announcements through the website. You can go to the AHRQ website in the upper right-hand corner, that little red box there, and sign up for email updates. Next slide, please. If you have further questions, you can email us at caps1@westat.com. Contact us by phone 1-800-492-9261 or visit the AHRQ website, www.arc.gov/CAHPS, CAHPS. Next slide, please. Thank you for joining us today. This concludes the presentation.